everyone. My name is Carolina Restini. I am a faculty at Michigan State University College of Osteopathic Medicine and a member of the Pharmacology and Toxicology Department. Along with Dr. Ricci, a member of the Biochemistry and Molecular Biology Department from this university, and with the fourth-year medical student, Jason Schick, we thank the board of Innovenc for inviting us to share an overview of our findings from the literature, in which we compiled the data on breast cancer, and as a team, we will present the update on breast cancer therapeutics and biomarkers. Part of the information we are presenting today was published early this year in the Breast Cancer Journal. Dr. Ricci and I will present a brief introduction, and Jason will walk us through the following topics of this presentation. The World Health Organization estimated that in 2020, almost 25% of all new cases of cancers in women was breast cancer. A paper published at the Annals of Oncology in April this year by Carioli and co-authors predicted similar rates for the UK and the European Union. The authors reported a reduction of these numbers compared with the data from 2015, which is a good news. But still, breast cancer in both European Union and the UK is the second highest rate in women predicted by the end of 2021. The first is lung cancer. Here in the US, by now, close to the end of this year, 2021, we are reaching 280,000 new cases of invasive breast cancer with an estimate of 40,000 deaths. As of January of 2021, there are more than 3.8 million women with a history of breast cancer. This includes women currently being treated and women who have finished treatments. This scenario prompts us to continue researching the many different prisms of the disease, which means aspects related to the developing of the tumor and therapeutic interventions. The treatment of breast cancer has been evolving over the last 45 years. In the US, the breast cancer incidence rates started showing a significant reduction from 2000, after increasing for the previous 2 decades. One theory is that this decrease was partially due to reduced hormone replacement therapy. In fact, the overall death rate from breast cancer decreased by 1% per year from 2013 to 2018 in the US. These decreases are thought to result from treatment advances and earlier detection through screenings. A fast evolution has been in the last 6 years with 18 FDA approvals of new drugs or new indications for pre-existing drugs. There is a positive correlation between the development of new technologies and an increased number of research testing for specific gene mutations related to the efficacy of the treatments. And also, because of the scientific development, we have more knowledge of differences among the subtypes of breast cancer. So, we will now cover relevant past and current pharmacological strategies available to treat different types of breast cancer and the importance of biomarkers for the prognosis, since they are targets that show promising results for future treatments. The aim of our presentation is to inform about the available treatments of breast cancer, to highlight the biomarkers currently being used and those with future potential, and to open the discussion for future directions of breast cancer therapy.
All breast cancers arise from the terminal duct lobular unit. Breast biopsy allows determination of the histological and molecular subtypes. For histologic classification, the first major division is in situ versus invasive carcinoma. For in situ carcinoma, the cancer cells are limited to the basement membrane, while invasive carcinomas extend beyond the basement membrane. Histological classifications can then be further divided into ductal carcinoma if it affects the ducts, or lobulocarcinoma if it affects the lobule. Invasive carcinoma is then broken down into multiple subtypes. Invasive ductal carcinoma is the most common subtype, followed by invasive lobular carcinoma. Molecular classifications of breast cancer have 5 main subgroups that have substantial clinical relevance. Luminal A is hormone receptor positive, expressing estrogen receptor and/or the progesterone receptor, human epidermal growth factor receptor 2 or HER2 negative, and has low levels of Ki67. Luminal B is HR positive, either HER2 positive or HER2 negative, and express high levels of Ki67. Luminal B cancers generally grow slightly faster than luminal A cancers. Normal-like breast cancer, like luminal A, is HR positive, HER2 negative, and has low levels of Ki67, but its prognosis is slightly worse than luminal A. HER2-enriched breast cancer is HR negative and HER2 positive and tend to grow faster than luminal cancers. Triple-negative breast cancer, basal-like, is HR negative and HER2 negative. Prognosis is best for luminal A and worst for triple-negative basal-like. Treatment is based upon subgroups of breast cancers and therefore expression of biomarkers. To better understand the importance of molecular subtypes for treatment, I will briefly go over some of the important signaling pathways involved with estrogen receptor, HER2, and some immunological signalings. In premenopausal women, estrogen is produced in the ovaries. In the breast cells, estrogen binds to the estrogen receptor, causing the receptor to dimerize and move into the nucleus. The dimerized receptor, once in the nucleus, then binds to estrogen-responsive elements, which are present in the promoter region of estrogen-responsive genes. These genes will then be activated to express proteins that are involved in growth. In postmenopausal women, estrogen is produced in the adipose tissue, where aromatase is involved. The signaling will be the same as the one for premenopausal women. HER2 is a member of the RBB family of receptor tyrosine kinases, which is involved in cell growth and survival. HER2 is a transmembrane tyrosine kinase receptor. When ligand bind to the HER2 receptor, it dimerizes. Dimerization leads to autophosphorylation of the receptor and activation of downstream signaling pathways. HER2 can activate the MAP kinase signaling pathway or the PI3 kinase signaling pathway, leading to activation of proliferation and survival genes. HER2 can dimerize with other HER2 receptors or with other members of the human epidermal growth factor receptor family, one example being the HER1 receptor. Dimerization with other members of the human epidermal growth factor receptor family will lead to crosstalk between different branches of the MAP kinase and the PI3 kinase pathways. Tumor-infiltrating lymphocytes include alpha-beta T cells and gamma-delta T cells. Accumulation of IPP in cancer cells leads to stimulation and activation of gamma-delta T cells. Activation is mediated by gamma-delta T cell receptor recognition of phosphoantigens presented by BTN3A1 on the breast cancer cells, and or interaction of MICA with NKG2D. Alpha-beta T cells may recognize and kill breast cancer cells by interaction of their T cell receptors with tumor peptides being presented by MHC1 molecules in the tumor cells. Breast cancer cells may express the immune checkpoint regulator programmed cell death ligand 1 or PDL1 to suppress anti-tumor immune responses by these alpha-beta T cells. PDL1 in the tumor cells interact with PD1 programmed cell death 1 receptor in the alpha-beta T cells present in the tumor-infiltrating lymphocyte region near the tumor and blocks activation of these T cells. These signaling mechanisms provide different molecular targets for therapy.
The first category of therapy we will talk about is chemotherapy. The main chemotherapeutic agents used for breast cancer are taxanes, anthracyclines, and cyclophosphamide, though platinum-containing agents can be added in cancers that are HER2 overexpressing. The mechanisms of action of these agents are varied. Paclitaxel and docetaxel are the taxane agents. They act through disruption of microtubule function, causing a block of mitosis. The anthracycline agents, doxorubicin and epirubicin, interact with topoisomerase 2, preventing religation of double-stranded DNA breaks. They then intercalate with DNA, inhibiting DNA and RNA synthesis, and they generate reactive oxygen species. Cyclophosphamide forms phosphoramide mustard, which creates crosslinks within and between adjacent DNA strands, leading to apoptosis. Carboplatin and cisplatin are the most commonly used platinum-containing agents. They act through cross-linking DNA, inhibiting DNA repair and synthesis. Chemotherapy is a standard of treatment for most forms of breast cancer, though absolute benefit may not be worth it in women with low baseline recurrence risk. This can be the case in some women with luminal A cancers. Similarly, studies have shown that the prolongation of overall survival is minimal or non-existent in patients with significant comorbidities or advanced age. Next are the selective estrogen receptor modulators, or Serums. They act as agonists of estrogen receptors in certain tissues while acting as antagonists in other tissues. Tamoxifen and raloxifene are the two most commonly used. They both act as antagonists in the breast, which is what gives them their therapeutic properties. Serums remain standard in treatment of ER-positive breast cancers. Studies have shown efficacy of tamoxifen and raloxifene for chemo prevention in people at increased risk, showing up to a 34% decrease in risk after 5 years of treatment. Serums increase the risk of thromboembolic disease, endometrial cancer, and stroke, which has led to low use of Serums for chemo prevention. Another form of anti-estrogen therapy are aromatase inhibitors. Anastrozole, exemestane, and letrozole are the aromatase inhibitors used in breast cancer and are used in ER-positive cancers. The mechanism of action is to inhibit the peripheral conversion of androgens into estrogens, therefore decreasing the available amount of estrogen to feed the tumor cells. Like Serums, exemestane and anastrozole have shown benefits in chemo prevention. Adverse effects include loss of bone mineral density and intensification of menopausal symptoms. Resistance is a key problem in aromatase inhibitor use, with it occurring in more than 20% of patients. This can be either developed resistance or resistance that was there from the start of treatment. One prevailing theory of resistance is genome silencing. The greatest predictor of the development of resistance is obesity. The final form of anti-estrogen therapy is the selective estrogen receptor degraders, which consists of one drug, fulvestrant. Fulvestrant inhibits estrogen receptor dimerization, which accelerates the degradation of the receptor. It is most commonly used as an adjuvant to other therapies, including CDK4/6 inhibitors and PI3K inhibitors. Severe adverse events include cardiac failure and arrhythmia. The next class of drugs are the cyclin-dependent kinase 4/6 inhibitors. This class currently includes 3 drugs approved for the treatment of breast cancer: palbociclib, ribociclib, and abemaciclib. They are used in advanced or metastatic hormone receptor-positive HER2-negative cancers. Their mechanism of action is through inhibiting the enzymes CDK4 and 6. This prevents them from forming a complex with cyclin D, ultimately preventing cells from exiting G1 and proceeding in the cell cycle. With the development of this class of drugs came the search for new biomarkers. Studies have shown that higher expression of CDK4, FGFR2, and ERB-B3 are associated with longer progression-free survival. Though these markers are not used clinically at this time, they have potential for use in the future. The most common side effects associated with CDK inhibitors are neutropenia and leukopenia. Phosphatidylinositol 4,5-bisphosphonate 3 kinase inhibitors are a newer class of drugs to receive approval for breast cancer. Currently, the class only contains one approved drug, alpelisib. It is indicated for hormone receptor-positive HER2-negative advanced or metastatic cancer that also contains a mutation in the PIK3CA gene. The mechanism of action is through inhibition of the enzyme PI3K. This leads to downstream decreases in AKT and mTOR activity, causing increased cell apoptosis and a decrease in cellular proliferation. Like the CDK inhibitors, implementation of this class has prompted the search for new biomarkers. Studies have shown some evidence that having more than one mutation in PIK3CA, or having mutations in both PIK3CA and MAP3K1, is associated with enhanced clinical benefit when using PI3K inhibitors. The most common adverse effects associated with PI3K inhibitors are hyperglycemia and diarrhea. The next class of drugs are the tyrosine kinase inhibitors. Neratinib, lapatinib, and ducatinib are currently approved for use in HER2 overexpressing advanced or metastatic cancer. They act through inhibition of different HER proteins, including HER1 through HER4. Typically, the adverse effects from TKIs involve the GI tract, such as diarrhea, nausea, and vomiting. Poly-ADP ribose polymerase inhibitors are the next class of drugs. Olaparib and talazoparib are the PARP inhibitors currently approved for the treatment of HER2-negative metastatic breast cancer associated with a BRCA mutation. Their mechanism of action is based on the pharmacologic principles of synthetic lethality. Poly-ADP ribose polymerase is an intranuclear enzyme that detects single-stranded breaks within DNA, then binds to them and repairs the breaks. Inhibition of this enzyme in combination with a BRCA1 or 2 mutation results in synthetic lethality or the decreased ability to repair breaks in DNA strands, causing death of tumor cells. Many biomarkers have been proposed as prognostic in treatment with PARP inhibitors, including TP53, ATM, PAL-B2, and RAD51C. Though none of these are used clinically, they are another avenue for future research and potentially tailoring of therapy for enhanced outcomes. Histone deacetylase inhibitors are a class of drugs that are currently under investigation for breast cancer, but do not contain any approved drugs at this time. The catalyst for investigation of HDAC inhibitors in breast cancer was centered around resistance to anti-estrogen therapy in ER-positive tumors. HDAC inhibitors take advantage of the gene silencing mechanism of resistance. They do this through their interaction with the DNA structure. Histone deacetylase is an enzyme that removes histones from amino acids within DNA, allowing the DNA to be wrapped more tightly. Inhibition of histone deacetylase causes hyperacetylation of histones and relaxation of chromatin, allowing higher transcription of DNA, thus potentially restoring the efficacy of anti-estrogen therapy. Monoclonal antibodies are a class of drugs indicated in numerous diverse conditions. Trastuzumab and pertuzumab are the monoclonal antibodies approved for the treatment of HER2 overexpressing breast cancer. Of note, pertuzumab is only approved for use in conjunction with trastuzumab and chemotherapy. They act through binding the extracellular domains of HER2 to decrease activation of the HER2 signaling pathway. Downstream pathways of HER2 include the PI3K, AKT, mTOR, and the RAS-RAF-MAPK pathways, which promote cell growth and oppose apoptosis. The most severe side effects involve the heart, specifically new or worsening heart failure. The cardiotoxicity is worse when pertuzumab and trastuzumab are used in conjunction. Antibody drug conjugates combine a monoclonal antibody with another drug to interrupt cancer cells through multiple mechanisms. Currently, there are 3 antibody drug conjugates for the treatment of breast cancer: trastuzumab emtansine, or TDM1, trastuzumab deruxtecan, and sacituzumab govitecan. TDM1 and trastuzumab deruxtecan are indicated for HER2 overexpressing metastatic breast cancer, with TDM1 having the added indication of use in early cancer with residual after treatment with chemotherapy and trastuzumab. Sacituzumab govitecan is approved for treatment of metastatic triple-negative breast cancer. TDM1 and trastuzumab deruxtecan combine the mechanism of trastuzumab with a chemotherapeutic agent. Emtansine is a cytotoxic agent causing mitotic arrest through binding tubulin, and deruxtecan is a topoisomerase I inhibitor which prevents DNA religation, causing the accumulation of damage to DNA and apoptosis. Sacituzumab govitecan consists of a TROP2 monoclonal antibody and an active metabolite of irinotecan, which is a topoisomerase inhibitor, preventing DNA replication and transcription. Although rare, serious adverse effects can include hepatotoxicity and development of interstitial lung disease. Immunotherapy is a growing form of treatment for all cancers, breast cancer included. Immune checkpoint inhibitors are one such therapy and include one currently approved drug, pembrolizumab. Pembrolizumab is approved for use in triple-negative cancer. This is significant for adding another treatment option for triple-negative cancers which carry the worst prognosis of all molecular subtypes. Pembrolizumab is an antibody that binds to programmed cell death protein 1, also called PD-1. PD-1 is an immune checkpoint, preventing the immune system from attacking the body's own tissues. Pembrolizumab prevents this action, allowing the immune system to destroy cancer cells. Another drug in this class, atezolizumab, was initially given accelerated approval in 2019. The confirmatory IMpassion 131 trial did not meet its endpoint, and the FDA stated that continued approval would be contingent on further studies confirming efficacy. In April of this year, the FDA Oncologic Drugs Advisory Committee voted to keep atezolizumab on the market. But then in August of this year, the manufacturer of the drug voluntarily decided to withdraw the approval. Gamma-delta T-cell stimulators are a new proposed method of immunotherapy. Currently, there aren't any drugs approved as gamma-delta T-cell stimulators, though. Trials have shown the efficacy of aminobisphosphonate, specifically zoledronate, for this indication. Zoledronate stimulates the expression of a subtype of T cell receptors on gamma delta T cells. This receptor is responsible for recognition of phosphoantigens that are overexpressed in cancer. This allows the immune cells to target cancer cells within the body. The Niazole study was the original study showing the efficacy of zoledronate as a gamma delta T cell stimulator for the treatment of breast cancer. Currently, 7-year long-term follow-up data is being gathered to further support the efficacy and potential approval of zoledronate as a gamma delta T cell stimulator. To conclude, breast cancer management is perpetually evolving, especially treatment of advanced and metastatic disease. This figure here indicates treatments that are actively in clinical trials, including multiple PI3K inhibitors, PARP inhibitors, antibody drug conjugates, and much more. The rapid evolution of therapy is being mirrored by the evolution and discovery of biomarkers with the potential for clinical use. Overall, this is leading, and hopefully will continue to lead, to improvements in prognosis and tailoring of therapy to individuals based upon their cancer pathology. Thank you very much, everyone, for your time and for listening. We will now be happy to take any questions.